I hope my audio and video is okay. So just drop me a confirmatory message in the chat box and then we can start with the session proper. So for today's session, what I have done, I have compiled 25 important MCQs from PSM which has been asked in different exams previously, and for the sake of remembrance, at least till exam, what I am doing, I am just taking the theoretical part in explanation as well. So the basic motive is to give you theoretical concept or to just brush up your theoretical concepts rather than marking the answer, because in PSM we don't have any some clinical clues or some keywords to get up to the answer. So here you have to just remember the theoretical concepts, and yes, PSM is extremely scoring provided you know the concepts, right? So we will go with the question, then we will try to discuss the options, and then we will reach up to the final answer. Okay, so the very first question is about all or none phenomena, and this is best described as termination of all transmission of infection, and how it is done by extermination of the infectious agent, right? So what is given here, let us write that first. So one of the statement is all or none phenomena. Okay, this is one thing. Now secondly, there is termination of all transmission of infection, and how it is achieved? It is achieved by termination of the infectious agent which is responsible for that disease. So what we are doing, actually we are removing the infectious agent from the community, and therefore now there is no termination, and now there is no possibility of transmission of infection because the agent itself is removed from the society. Now what is this known as? So there are four options: disease control, disease elimination, disease eradication, or disease surveillance. Now let us take the options one by one, and the first option is disease control. Now as the name suggests, the problem is within the control, but it is not eradicated or it is not removed from the community. So here what is being done? Reduction of incidence and or prevalence of a condition to an acceptable level. So the number of new cases or the total number of cases of a particular disease are reduced to a acceptable level, that is disease control, and here we need continuous measures, right? So the disease is there, but the number of the patients are reduced so much that they are considered acceptable in a society. So that is disease control. Now the another word is disease elimination. Disease elimination means that the reduction has been done in the number of cases to zero incidence. It means the number of new cases are zero in a well defined geographical area, and here we need continued intervention. So the number of new cases are zero. So zero incidence, that is elimination. Now the third and the most important is disease eradication. Now what does eradication means? In eradication we are having zero incidence, and that is not limited to a specific geographical area, that is worldwide. So zero incidence worldwide, and this is which is caused by a specific agent, and once this is done, we need not do anything else, right. So, that is disease eradication. Now, disease eradication is all or none phenomena, and it means that there is complete termination of transmission. Now, there is no transmission of the disease, and why there is no transmission of the disease? Because we are removing the infectious agent from the society. So, the infectious agent which is responsible for the transmission is finally removed from the society. So, that is disease eradication. And if we go for a classical example, that is smallpox, which was declared eradicated in 1980. So, this is disease eradication. Now, surveillance, as we all know, it is just monitoring. Surveillance means monitoring, like CCTV surveillance. So, it is just monitoring. So, it is continuous monitoring of the disease occurrence. But what is more important for you to remember out of this question is the definition of disease control, disease elimination, and disease eradication. So, eradication, as the name suggests, it is worldwide, but elimination is in a defined geographical area, and in both the cases there is zero incidence. And I think most of you must be knowing what we mean by the word incidence. Incidence is number of new cases. So, there is no new cases of a given disease. So, that is zero incidence. So, if there is zero incidence in a specified geographical area, we will call it disease elimination. If there is zero incidence worldwide, that will be known as eradication. So, in relation to zero incidence, we can write two possibilities. Either it is in a specific area or it is worldwide. If it is in a specific area, you will call it disease elimination, and if it is worldwide, you will call it eradication, right. So, is that clear? Elimination from a specific area, eradication worldwide. So, this is how you should remember these definitions, which are pretty confusing but very frequently asked in the exam. So, elimination, eradication is very important. And how we can do disease eradication? If we can terminate the infectious agent. So, if the infectious agent is gone, then there will be no disease transmission. So, just remember these two important definitions: disease eradication, disease elimination. And in disease control, the word itself is suggesting control. So, it means the number of cases are there, but they are not creating any problem. So, they are within an acceptable level. So, disease control, disease elimination, disease eradication, these are the three terms which are very frequently asked. So, that is disease eradication, which is an all or none phenomena. It means there is no transmission of any infection. And why there is no transmission of infection? Because the infectious agent has been removed worldwide. So, that is disease eradication. Great, right? Yasser, good evening. Bache, good evening. Nice to see you. Okay, so please be clear in the definition of disease elimination and disease eradication, which is very frequently asked, and the only clue is the location. In a specific geographical area, disease elimination; worldwide, disease eradication. Okay, so I am very sure that you would not do any mistake in these kind of definition based questions, right? Now, next question. Many patients with unexplained rash and fever were reported from a village close to the primary health center, right? So, rash and fever, and there are many patients who are having this problem. They come to the PSC. Now, what is the first step in initiating the investigation of such an epidemic. So here I think most of you must be knowing the definitions of endemic, epidemic and pandemic. Very good evening Kakul. And pandemic, right? So endemic, epidemic and pandemic. Now endemic, it is localized to a specific area of a country. So endemic means localized. Like Japanese encephalitis is endemic in Gorakhpur side of area, Kala Azar is endemic somewhere in Bihar. Like, so the condition is occurring more in a specific area. So number of cases are more in a specific area. Then epidemic, the number of cases are more than expected over a larger area. And pandemic, when it involves the entire world. And I think most of you must not have forgotten about the COVID-19 pandemic. So pandemic means involving many countries, crossing the boundaries of the countries. So now this is just basic definition of endemic, epidemic and pandemic. Now here we have to go for this word epidemic, where there are many patients who are coming, which is more than the number of the expected number of that particular disease. Now here we are having many patients, and therefore we have to investigate whether there is epidemic or not. Now what is the first step in initiating the investigation of an epidemic? So first step in initiating the investigation of such an epidemic. Now here, whenever we are investigating epidemic or an outbreak, the very first step is to verify the diagnosis, verification of diagnosis. So the first step is to verify the diagnosis, right? So we have to verify the diagnosis of that particular condition. Now how it can be done, how you can diagnose? Obviously clinical examination of cases, then laboratory reports, and then make sure you don't misdiagnose it. So ruling out misdiagnosis or some laboratory error. So that is how we will finally reach up to the diagnosis. So that's verification of diagnosis. So the very first step is diagnose the condition. Then once you have verified the diagnosis that okay, yes, these cases are of this particular condition only, then we need to proceed. So only after verification that the reported cases are real and correctly diagnosed for a particular condition, then we proceed to further steps in the evaluation of epidemic. So the second is confirm existence of epidemic, that in reality the epidemic is occurring. Then define and identify cases, then do rapid search for cases, define population at risk, analyze the data. So that is all sequence later on. But what is very frequently asked is the first step, and for first step please remember verification of diagnosis. So from exam point of view you have to remember only 2 points. What is the first step? That is verification of diagnosis. And what is the second step in evaluating an epidemic? And that is the confirmation of existence of epidemic, right? In reality the epidemic is occurring, so you can just write it like this: confirmation of existence of epidemic. Clear? So only these 2 points are frequently asked. Number 1, verification of diagnosis, and number 2, confirmation of existence of epidemic, right? So if you remember these 2 points, I am very sure you will not do any mistake in such kind of questions, and this is the one which is very frequently asked, how you will investigate an epidemic, right? So please don't do any mistake in this. So verification of the diagnosis is the very first step. Now moving forward to some calculation based question, and now these are very commonly asked, and it's pretty simple provided you know the basic concept, basic formula, and then it's very easy. Now there is a table which is showing diagnosis of myocardial infarction by ECG. So on one side we see the ECG results, positive, negative, and on other side the disease present or disease absent, right? So this is disease present, this is disease absent, and on the left side we can see, say, test positive, test negative, right? Now here we have to talk about 2 things, whether the sensitivity is 90% from this table or whether the specificity is 80% from the given table. So now let us take this table, let us study this table properly, and then we can comment on the appropriate answer. So now here what is written, see, in case of a positive ECG, means we are looking for, suppose we are looking for ST segment elevation, right? So you can write here ST segment elevation, and here we are discussing it as an screening test. Clear? So the key topic here is screening test. Now the screening test positive means it is showing ST segment elevation. Screening test positive means, so if I write it here, screening test positive means it is showing ST segment elevation, and screening test negative means there is no ST segment elevation. So this is what we mean by the word positive. So this is positive here, right? So this is the positive, and this is negative, so this is negative. Now what can happen? Even though test is positive, it means there is ST segment elevation, but it is not necessary that all patients will have myocardial infarction. So what is happening here? There is 2 possibility, MI is present or MI is absent. So despite having ST segment elevation, myocardial infarction can be present in the patient, or the patient is normal and the test is showing it false positive. Similarly, here again 2 possibilities, patient can have myocardial infarction or patient is absolutely normal. So that is what is mentioned as myocardial present or myocardial absent. Now let us take the data. The disease, that is myocardial infarction, is positive in 45 patients, right? So it is present in 45 patients in whom the test is positive, it means there is ST segment elevation, and it is present in 5 patients although there was no changes in ECG. So ECG is normal, but the patient is having the problem. Similarly, there was no disease in patients and the ECG was positive. Similarly, there was no disease and the ECG was negative. So these are the values which has been written as. So here test positive, disease positive, then okay, so this is test positive, disease positive, this is test positive but disease negative. So when the test is positive but disease is absent, such a test is known as false positive. Okay. So false positive means the test is coming out to be the positive, but the patient is not having the disease. So therefore it will be known as false positive. Now let us take the another word. The test is positive and disease is present. Now what this will be known as? This will be known as true positive, because the patient is showing a positive test and the disease is also present. So that's true positive, right? So that's the concept of true positive and false positive. Similarly, you will reverse it, true negative and false negative. Okay. So that's very important. Now suppose if I am writing this test positive, disease positive, this is true positive, and I will write it TP, true positive. For test positive, disease absent, I will write false positive. So TP, FP is true positive and false positive. Similarly, FN is false negative. It means the disease is present. So if I just reverse it, if I say disease is present but the test is negative, so this will be known as false negative, because the disease is present but the test is not checking it. So that is false negative. You will write it FN. Or there is one more possibility, that the test is negative and disease is also absent. So this is true negative, because the test is negative and the patient is also normal. So that's true negative. So these are few words which you should know: true positive, true negative, false positive, false negative. And true means like you have both the things are correlating, means like if I am asking about true positive, means test is positive, disease is positive or disease is present. True negative, test is negative, patient is normal, disease is absent, right? And just reverse the two. So that is how you will get the values. So if the disease is present and the screening test is positive, we will get the true positive. So this is the true positive. Test is positive, disease present. Similarly, if the test is negative and disease is absent, we will get true negative, right? So these are the two important things: true positive, true negative. Now reverse it. The test is positive but disease is absent. So this will be known as false positive, because disease is not there but test is coming out to be positive. So that is false positive. Similarly, reverse it. Test is negative but the patient is having the disease. So this is false negative. So understood? True positive, false positive, true negative, false negative. Now you should know what is the formula of sensitivity. Sensitivity. So for sensitivity, what we will do, we will take true positives, right? So we will take the numerators as true positive and the denominator will be the true positive and false negative, right? So in sensitivity, what we are doing, we are taking the true positive as the numerator and the denominator is true positive plus false negative. So here 45 is the true positives, means ECG is showing ST segment elevation, patient is having myocardial infarction. Then the denominator is the sum of true positive, again the disease is present, ECG showing ST segment elevation, and false negative. It means the patient is having the disease but it is not picked up on the ECG. So that will be the denominator and therefore sensitivity will come out to be 90%. So this is the numerator and these two the sum is the denominator for sensitivity. Now coming to specificity. Specificity means we'll take the numerator as true negative, means test is negative, disease is absent, that is true negative. So the test is able to exclude the disease. It is not showing any positivity because the patient is normal. So that is true negative. And the denominator will be the sum of true negative and false positive. So this will come out to be the numerator, and the sum of these two will be the denominator. Now false positive. False positive means the test is positive but the patient is normal, right? So this is false positive. So again we will add the entities here and we will get it as 80%, right? So if we look at the options, sensitivity 90%, yes it is 90%, specificity 80%, yes it is 80%. So it means both the statements are true considering these values of the given table. The only thing which you need to remember is the formula of sensitivity, true positive upon both the entities in the disease present, and for specificity, true negative and both the values in the disease absent state. Clear? So that includes false positive or true negative. So if you remember this much, it's very easy. And moreover, you can remember this: true positives means the test is positive in the presence of disease. Specificity, true negative, the test is negative in the absence of disease. Clear? So that's very commonly asked. Please remember it nicely. And yes, before that you should know what is false positive, what is false negative, what is true positive and what is true negative. Then only you can solve such kind of questions. So it's not difficult provided you have that basic concept in your mind. So both the statements are true here, so answer will come out to be both 1 and 2. Now next question: while performing triage in response to disaster with commonly internationally accepted 4-color code system, which one represents the highest priority for emergency response? Means if there is a disaster, obviously there will be many casualties. Now we do color coding, and this color coding help us to identify, okay, these patients, they need emergency care. So what label has been given to those patients? Now black, green, red, yellow. So out of these 4, 2 are extremely important from exam point of view, and these are very frequently asked. One is which one needs extreme priority, and the second one which does not need any attention at all. So 2 spectrum, ends of the spectrum that you should know. So one is obviously the red, which needs immediate care because there are some life-threatening injuries, but we can manage them. So if we can treat the patient timely, we can save the patient. And the second one which you should know is the black label. It means the patient is already dead or he is about to die. And we can also use one word, moribund, means about to die. So even if you do anything, the patient will not survive. So there is no point in giving any attention to such patients who have been given a black tag. But yes, all priority for red, because if you don't do anything, definitely they will die, right? So red needs priority in the treatment protocol. So this is the triage system in disaster management, and here we are using 4-color code system: priority for red, 0 priority for black. right? And in between these two, we have yellow, where the priority can be delayed as compared to red, and green, which is having minor injuries and the patient can walk even though he is having injury, right? So this is the decreasing order of giving priority to the patients in tri-H: red, yellow, green, black. Clear? So the red one is the one which needs utmost attention and emergency care, and black, no need to look after them at all, because they cannot be revived despite best efforts. So this is the system of tri-H, and this is very frequently asked. I think all of you must be knowing that. Then next question from occupational diseases, and which is one very favorite segment for exam setters. Always and always they include one question from this topic. So on a chest radiograph, which of the following occupational disease is most likely to be mistaken for tuberculosis of lungs, right? So the radiological appearance of one occupational lung disease looks like tuberculosis of lungs. So we have to be very careful. So that condition is silicosis. Okay, so that condition is silicosis. So the occupational lung disease which is most likely to look like pulmonary tuberculosis on chest X-ray is silicosis. Now, what are the radiological features which are seen in silicosis? It produces upper lobe nodular opacities, fibrosis, and sometimes cavity formation, right? So opacities, fibrosis, and cavitations, and this is also strongly related to reactivation of tuberculosis, and then the condition is known as silicotuberculosis. And in both the conditions, what we can see, there is involvement of upper lobe, there are fibrotic changes, and more importantly there is formation of cavities, and therefore at times we are confused whether we are looking at an X-ray of silicosis or pulmonary tuberculosis. So that's very important. Silicosis can look like tuberculosis on chest X-ray. Now next question, again from a very important topic, biomedical waste. So under the biomedical waste rule 2016, the human anatomical waste is to be carried in which color plastic bags? Human anatomical waste. So here this is about human anatomical waste. I think most of you must be knowing the answer, that anything soiled with blood or body secretions has to be discarded in yellow bag. So under the biomedical waste management rules 2016, human anatomical waste like tissues, organs, or some body parts which have been amputated, like some amputated limb or placenta, they all should be discarded in yellow bag, right? So this has to be discarded in yellow bag, right? So yellow bag, human anatomical waste or soiled waste, also microbiology waste, and expired medicine. So these are all which will be discarded in yellow bag. And how it is disposed of? By incineration or deep burial. So human anatomical waste, yellow bag. Please remember that. Then next question, in a child who has not received any dose of DPT vaccine, diphtheria, pertussis, tetanus vaccine, and oral polio immunization, up to what age can these vaccines be given under the universal immunization program, right? So universal immunization program. Now the child has not received any DPT nor oral polio vaccine. Now, what is the maximum age till which these vaccines can be given under universal immunization program? So here, if the child is completely unimmunized, DPT vaccine can be given maximum till the age of 7 years, right? So suppose if the child which is coming to us who is fully unimmunized, he is 6 years old, we can give him DPT vaccine, right? So till the age of 7 years, we can give DPT vaccine if the child is not immunized at all. But for oral polio vaccine, the age limit is only 5 years, right? So DPT vaccine till 7 years and oral polio vaccine till 5 years. So that's the takeaway message from this question. In a completely unimmunized child, right? So this is the maximum time limit till which we can give these vaccines under universal immunization program, right? And if the child is coming after 7 years, then we will not give the pertussis component. So in this case, beyond 7 years, we will give only the diphtheria and the tetanus component. So tetanus toxoid or TD, right? So we will remove the pertussis component from here after 7 years. So DPT till 7 years, OPV till 5 years, as simple as that. So just memorize it. Then a traveler who has passed through a yellow fever endemic zone and does not have a certificate of vaccination against yellow fever, now he enters a yellow fever receptive area. For how long from the date of leaving the infected area must this traveler be placed on quarantine in a mosquito proof ward? Now here again you are getting this word endemic. So endemic means in a certain area some particular disease is very prevalent. There are high incidence, there is high number of cases in that particular zone, and for yellow fever the person has to have a yellow fever vaccination certificate to enter into that area. Now suppose if the person is unimmunized, he enters into that yellow fever endemic area, there is possibility that he might contract the disease. Now when he moves out of that endemic area and moves to a yellow fever receptive area, there is possibility that he might have that infection. So what we need to do, we need to put that fellow on quarantine so as to check whether he has really contracted the disease from that endemic area or he hadn't. So he should be placed in quarantine. Now here I think most of you must be remembering the word quarantine, especially in relation to COVID-19. Whenever we came back to India from some other country, we were subjected to a 14 days quarantine for COVID-19. So it was 14 days. Now what actually this 14 days? Why only 14 days, not only 10 or 20? So this is actually the incubation period of COVID-19, right? So the fellow was kept under scrutiny for 14 days or till the incubation period of the disease to look for symptoms. If there are no symptoms after 14 days, it means the fellow has not contracted the disease. If the fellow shows symptoms, then he is treated accordingly, right? So that is the purpose of quarantine. So here in yellow fever, the quarantine rule is again based on the concept of maximum incubation period, which is around 3 to 6 days, and therefore we have to keep the patient under quarantine for the maximum length of incubation period, that is 6 days. So this will come out to be the answer here. So up to 6 days, because that is the maximum infectious incubation reference used for quarantine decisions. Now we are getting one word, yellow fever receptive area. Now what this mean? What is this word receptive? Now this receptive area means that the yellow fever virus is not naturally present there, but the vector is present, right? So the virus is not present, but the vector is present. Now if suppose this is endemic area and then this is a receptive area. In endemic area virus is present and here the virus is absent. Now what happens if a patient travels from endemic to receptive area, he might be carrying the virus. So virus might be present, absent, might be carrying. Now if he is not kept under quarantine, the vector which is present here, it might spread the virus. So there is possibility of disease transmission. So what we need to do? We have to keep the fellow under quarantine and we want to make sure that the vector does not come in contact with the fellow. So that's why we are keeping that fellow under mosquito proof ward. So just to make sure that even though he might be carrying the virus, the vector does not have access to that virus, otherwise he will transmit that virus to other normal population. So receptive means the virus is absent but the vector is present, and here the vector is obviously Aedes aegypti, right? So if we do not take proper precautions and if the virus is introduced by that fellow traveler coming from the endemic area, this virus can be transmitted by the vector. So vector is already present, virus is usually not present in the receptive area, but it can be brought from the endemic area by some traveler who is traveling to receptive area, right? So that's the definition of receptive area here. Now if somebody is non-vaccinated who is coming from yellow fever endemic area to receptive area, we need to keep him away from the vector, that is Aedes aegypti mosquito, and till how long? Till the period of maximum incubation period of leaving the infected zone. So that's 6 days in yellow fever. So that's the concept of quarantine, endemic, I think all of you must be knowing, and receptive area in terms of yellow fever. So that's a very beautiful concept, and yes, yellow fever is extremely important topic from exam point of view, and here sometimes we have some more questions from yellow fever, like suppose if somebody is vaccinated, when does the immunity start? So the immunity starts on 10th post vaccination day. Clear? So suppose if somebody is vaccinated on 20th, the immunity will be developed by 30th and then he can travel freely. So this is the 10th post vaccination day, the onset of immunity, and then this immunity lasts lifelong. So it means if somebody is immunized once, he will remain immune forever. That's very important. Okay, so this is yellow fever, very important from exam point of view. So keep a non-vaccinated fellow under quarantine for 6 days, that is the maximum incubation period for yellow fever. The next question, in a case of 7-year-old school-going child, what is the most appropriate indicator to measure the current nutritional status? So here the age has been given 7 years. Now indicator of nutritional status indicator. Now there are some indicators which are given here, but they are age specific, like mid upper arm circumference, right, mid upper arm circumference, and this is mainly from 6 months to 5 years, 6 months till 5 years, and has no role in a child of 7 years. So this is for 6 months till 5 years. Then birth weight has nothing to do with current status. It will just simply indicate the past intrauterine nutrition. Head circumference, that is mainly for brain growth, right, in infancy. Now infancy means the age is less than 1 year, right. So head circumference related to the growth of brain in less than 1 year. Now weight for height, it is also used for under 5 children, right. Weight for 5 is used for under 5 children, and this is to check wasting of muscles. Now here, if you look properly, none of the option looks directly associated, because for children of 5 to 14 years, for evaluating the current nutritional status, the best indicator is BMI, right. So the best indicator is BMI, but we don't have any option as BMI, so the nearest one can be taken as weight for height, right. So weight for height can be replaced for BMI, and if we know the formula of BMI, that is weight upon height square, so that can be substituted. Otherwise BMI for age is the best formula for best indicator for evaluating nutritional status of a child from 5 years till 14 years, right. Below 5 years, best is mid upper arm circumference. Kashmiri Phi tubecast, thank you bache, thank you, but I couldn't understand your name as such. So anyway, so for the time being, what you need to remember, less than 5 year, right, you will write mid upper arm circumference, and more than 5 year BMI for age. Clear? That's very important. Obviously there will be limits like 6 months to 5 years, 5 years to 14 years. So for the time being, I am just taking this distinction in terms of 5 year. Thank you Mirza Amar Beg, really nice to see you here, but I think this session is not for you. You are already working in hospitals, right? Anyway, so this is weight for height, which is the nearest appropriate option in this case. So less than 5 year, go for mid upper arm circumference. More than 5 year, go for BMI for age, or you can also write weight for age. Clear? Chalo. Then next question, which is again, thank you, really nice to hear from you after such a long time. So next question is open vial policy. Now I think most of you must agree that this is also one of the most important topics which we have seen over the years. Every time we have a question from this topic, open vial policy. Now here, partially used multi-dose vials of which of the following vaccines can be used over more than one immunization session, right? So what happens in multi-dose vials, we can use only 1 dose, 2 dose at a time, and then the remaining dose is left. So for some vaccines, we can use that remaining dose, provided the cold chain is maintained, at some later session. So that is known as open vial policy, where we can reuse. For some, after the session, we have to discard whatever the amount of dose is left in the vial. So that's the policy that applies to certain vaccines which can be used. For certain others, we have to discard whatever the amount is left. So now here, This open vial policy is applicable to which vaccines? So, as per the open vial policy under India's universal immunization program, vaccines that can be used in subsequent sessions, means suppose if today we have used some dose, then the remaining left dose in that multi-dose vial can be used maybe after a week or after 10 days. So, that is open vial policy. We can use it after some time, and this applies to DPT vaccine and hepatitis B vaccine in the given question. So, DPT and hepatitis B. Now, these are liquid vaccines which contains preservatives, and they can be used up to 28 days of opening the vial, provided the expiry date is not crossed, the cold chain is maintained, and vaccine vial monitor, we have to look at that also, that is not at the discard point, and obviously aseptic technique is maintained. So, if the conditions are fulfilled, we can use the remaining leftover dose in that multi-dose vial, especially for hepatitis B vaccine and DPT vaccine. Now, some vaccines which should not be used in subsequent sessions, this is especially for the ones which are reconstituted like BCG and measles. Now, these are freeze dried vaccines or lyophilized vaccines, and they should be discarded within 4 hours of reconstitution. Once you prepare them, you have to use the vaccine within 4 hours. After 4 hours, whatever the amount of vaccine is left, you have to discard it, right? So, after 4 years, we cannot use the reconstituted vaccines, especially BCG and measles, right? So, open vial policy guide us that. Rahim Anwad, thank you bache, thank you so much for your motivating comments, right? So, for the time being, open vial policy, what you need to remember, relates to multi-dose vials. The vaccine can be used again and again till a period of 28 days, subjected to fulfillment of conditions. But some vaccines, like the ones which are reconstituted, they should be used within 4 hours of reconstitution. After that, discard them. Okay, so after that, don't use them, right? So that's open vial policy. And for open vial policy, remember 2 important examples: DPT vaccine and hepatitis B virus vaccine. Clear? So this is open vial policy, right? Open vial policy. Don't confuse it with oral polio vaccine. OPV means open vial policy. Okay. So this is very important and has been repeated many number of times. Please don't do any sort of suicidal error in such easy and important questions. Now, next question: while calculating total dependency ratio, what is the denominator? Now, these kind of questions are very frequently asked. Some formulas, what is numerator, what is denominator, or sometimes they will give you values and then you are supposed to calculate the answer. So, please try to be perfect with formulas as much as possible. Now, coming to the word total dependency ratio. Now, total dependency means the fellow is completely dependent, and there are 2 extremes of the age group where the family members are dependent, totally dependent. One is till the age of 14 years, right? So, one is till the age of 14 years, clear? So, this is one till the age of 14 years, and second is beyond 65 years. So, if we just plot it on a line something like this, so say this is 14, this is 65 year. So, the members in this range and the members in this range, they are included as the numerator of the total dependency ratio. So, the numerator is less than 14 or more than 65, and the denominator is the population in this range. Clear? So, the denominator is, so this is the denominator, this is numerator 1, this is numerator 2. So, the formula can be like this upon denominator, and this is the total dependency ratio. Is that clear? So, less than 14 plus more than 65 will be the numerator, and between 14 to 65 will be the denominator. So, the answer will come out to be the option C, population between 14 to 64 years. Okay. So, this is very important. This is how you should remember this. Okay. So, total dependency ratio, very frequently asked. The next question, a 6-year-old boy was returning home from school. At the gate he was scratched by a dog, and there was some bleeding from the wound. What should be followed for post-exposure prophylaxis? Now, these kind of questions are very common in exam. So, what are the findings here? Scratch and bleeding wound, right? So, this is a scratch by a dog and bleeding wound. Now, what should be done here as a part of the post-exposure prophylaxis? Post-exposure prophylaxis. Now, firstly, we need to categorize it. Obviously, there is involvement of dog. So, I think most of you can understand what condition we are discussing. It is the possibility of rabies. So, this post-exposure prophylaxis is in terms of rabies. Now, what we need to do in such a case? Now, if there is a dog scratch with a bleeding wound, this comes under category 3 of rabies exposure. So, that is very important. Category 3, scratch plus bleeding, this is category 3. Now, why you call it category 3 and not category 2 or category 1? Because there is, that's including scratch. So, a scratch is there, then there is a break in skin with bleeding. So, scratch plus bleeding makes it category 3, and there is contamination with the saliva of the dog. So, there is all possibility of transmission of the virus. So, what should be done in category 3, which includes scratch plus bleeding wound? So, here the very first thing is immediately wash the wound with soap and water. That is very important. So, the very first thing is you have to wash the wound with soap and water, then give anti-rabies vaccine along with rabies immunoglobulin. Clear? So, here you have to give both type of immunization. This is active and this is passive. So, both type of immunization, right. So, here what will be your answer? Cleaning of wound, active immunization by anti-rabies vaccine, and passive immunization by rabies immunoglobulin. Clear? So it is infiltrated in and around the wound. So that's very important. For category 3, what you need to do? Wash, active plus passive immunization. So sometimes we have question where we need both, where we can use both active and passive immunization. So one of the answer is rabies, another one is hepatitis B also. So here we need to give both active plus passive. So this is very important for type category 3, sorry, active plus passive plus wound care, right? So that's the takeaway message from this question. And we have just discussed what is category 3. There is scratch plus, most importantly, there is bleeding from the wound. So the category 3 is the one which is very frequently asked. Then moving forward to the next question, here a statement has been given. The people should seek to preserve their traditional eating patterns, right? So preserve their traditional eating patterns and lifestyles associated with low levels of coronary heart disease. So here what is happening? The lifestyle modification, and this is an attempt to reduce the chances of coronary heart disease. So this is which level of prevention? Now this is a classical primordial. Why primordial? Because it is focusing on maintaining healthy traditional lifestyle. Then the emphasis is on the prevention of the emergence or the appearance of the risk factor. And how it can be done? By dietary change, sedentary habits. So we just want to make sure that those risk factors should not come. There should not be any dietary change, there should not be sedentary habits. And the population is addressed before the risk factor comes or there is emergence of risk factor. So this is primordial level of prevention. So in primordial, because whenever we discuss level of interventions, we discuss 2-3 things, like first is risk factors, then second is presence of disease, then third is presence of complications. So the level of prevention which is acted before the emergence of risk factor, this is primordial. Then in some cases risk factor is present but the disease has not occurred. So here we will apply primary level, right? We don't want the disease to come although the risk factors are there. Then the disease has occurred but the complication has not occurred, so we will go for secondary level of prevention. And lastly, we will go for rehabilitation, that is the tertiary level of prevention. So this is the tertiary level. Clear? So the keywords are risk factors, disease, complication. Before the emergence of risk factors, primordial. Before the occurrence of disease, primary. Before the occurrence of complication, secondary. And after complications, for rehabilitation, tertiary. So that you should remember. Now here the risk factors are not yet appeared. So this is primordial, and this is mainly by promoting healthy lifestyles. So we need not want, we don't want the patient to consume oily food, carbohydrate rich food, or to have a lazy life, because that will act as a risk factor, and that will lead to occurrence of the coronary heart disease condition, right? So that's primordial. So primordial, prevent risk factors. Primary, prevent disease. Secondary, prevent complications by detecting the disease at an early stage, and tertiary to prevent disability or rehabilitation also you can write. Clear? So that's how you should remember levels of intervention or levels of prevention, and I think most of you must be knowing that it is an extremely important topic from exam point of view. Please remember this, because many times what happens, like they will give you some scenario like vaccination is which level of prevention. So I think all of you can answer that vaccines is classical primary level of prevention, because risk factors are there, the organism is there in the community, but we don't want the disease to occur. So the classical example of primary level is vaccine preventable diseases. Then secondly, if we are applying a screening test, then that is which level of prevention. So here it is secondary level, because we are trying to diagnose the disease at an early stage. And then rehabilitation is obviously tertiary level, where we want to limit the disability or we want to rehabilitate the patient. So these are classical examples, and for primordial obviously it's about healthy lifestyle. So this is how you should remember important key clues, and that will help you in the exam. Then moving forward to next question, patient Raju is 30 years of age and he is working in ceramic and pottery industry for the last 10 years. Now which condition, which occupational condition he should be screened for? Now the person is working in ceramic and pottery industry, which is causing exposure to silica dust, and therefore he should be evaluated for silicosis. So what is the condition for which a person working in ceramic or pottery industry should be evaluated? Silicosis. So silica dust can cause silicosis, especially in stone cutting, mining, pottery, ceramics, sandblasting. So this is all scenarios for development of silicosis. And in one of the previous questions we discussed that silicosis chest X-ray findings looks like pulmonary tuberculosis. Clear? So both of them are having more or less same chest X-ray findings. Anthracosis, this is because of coal dust exposure, especially in coal miners. Bisonosis, I think everyone knows that it is cotton dust in textile workers. And asbestosis is asbestos exposure, especially in shipbuilding or insulation. So some specific jobs and some related conditions. Okay. Then moving forward to next question, an industrial worker was brought to the medical facility due to health problems, and on his workup what we saw that there is basophilic stippling of the red blood cells. Now the moment you have this word basophilic stippling of RBC, right? So suppose if this is RBC, you will see some basophilic stippling like this in the peripheral blood smear. So the moment you have this word, always think of lead poisoning, right? So this is a classical clue for lead poisoning, right? So basophilic stippling of RBCs is a classical hematological finding in lead poisoning, because lead inhibits one enzyme of the heme synthesis pathway, and therefore there is accumulation of ribosomal RNA within the RBCs, and that causes basophilic stippling. So this is actually all ribosomal RNA, right? So this is because of inhibition of heme synthesis by lead. Then asbestos, that will lead to lung fibrosis, farmer lungs, that is hypersensitivity pneumonitis, and then lead poisoning is what we have already discussed. Brucellosis has no RBC change as such. So this is basophilic stippling, classical for lead poisoning. The next question, National AIDS Control Organization. It provides pre-packed color code kits as free supply through its sexually transmitted illness clinics. Now there is a table in which on one side there is color of the kit and second is the condition for which that kit is given. Now we have to identify which one of the pair is perfectly or correctly matched. So for this is the table actually. So gray colored kit is given for urethral discharge. So gray colored kit is given for urethral discharge or anorectal discharge or cervical discharge. Then green color is related to female only, especially vaginitis. Then white color related to genital ulcer disease, especially bacterial, that is non-herpetic. And there is modification of this, that is blue, if the patient is penicillin sensitive. So here we are giving oral drug. So here we give tablets. So type 3 and type 4 is for same condition, but only the drug which is given differs, because in type 3 we are giving injectables. So here we give injectables, but in type 4 it's a modification of type 3 where we cannot give injections because the patient is sensitive, so we need to give tablets. Then type 5 is genital ulcer disease but herpetic, that is herpes genitalis, and this is red color. Then type 6 is yellow colored kit for lower abdominal pain, and 7 is black for inguinal bubo. So these are the different color of the kits and the conditions for which those kits are given, and this is actually known as the syndromic approach for sexually transmitted diseases or sexually transmitted illnesses. So rather than making a specific diagnosis, we are just asking for the symptoms, and based on that the medical facility person is giving the kit including of certain drugs. So now if we can see here, the green one is perfectly matched because it is given for vaginitis. Red one is not for urethral discharge. The red one is for genital ulcer disease, especially viral, that is herpes genitalis. So that's red. And white is also not correctly matched because white is for genital ulcer disease. Non-herpetic means especially bacterial. So this is non-herpetic, and here we are giving injection penicillin, benzathine penicillin, right? So that's very important. So this is how you should remember this color coding of the kit for which syndrome and what are the components. So for the time being I am skipping the component part because that will make the discussion much more lengthier. So for the time being, just remember that red for herpes genitalis, green for vaginitis, especially related to female, and white for genital ulcer disease, non-herpetic, that is bacterial but injectable, and patient is not sensitive to penicillin. And if the patient is sensitive, then this white will be converted to blue, where we will give tablets only, not injections. So only the one pair is correctly matched, and that is the green kit for vaginitis. So the answer is only one pair is perfectly matched. Clear? Then moving forward to another question, where the test results of ELISA for HIV infection is given. Now again here we have to calculate the sensitivity and the specificity. So sensitivity and specificity. So here we have this table with us. So test positive, patient diseased, this is true positive, isn't it? True positive means true positive. Positive means the test is reactive, and when we use the word true, it means disease is present. So the patient is having the disease and the test is coming out to be positive for the disease, then we will call it true positive. Now if the test is positive but the patient is negative, so this will come out to be false positive, right. So in false positive, again we will take this concept, false positive. Whenever the test is positive like this, and false means disease absent. The person is normal, person is not having the disease, but the test is coming out to be positive. So that is false positive. Now simply reverse it. The patient is not infected, the test is negative, so this is true negative, right. So true negative means test negative, patient negative for disease, and then the patient is infected but the test is coming out to be negative, this is false negative. So the test is showing negative but the person is having the disease, so that is false negative. Now we need to calculate the sensitivity, and if you remember what we did for sensitivity, the numerator was true positive and the denominator was true positive and false negative, right. So this was the denominator for sensitivity. Similarly, if we have to calculate specificity, the numerator was true negative and the denominator was true negative plus false positive. Clear? So we have to take this axis for as a denominator of sensitivity and this axis as a denominator for specificity. So let us take the values now here. So in sensitivity, the numerator is this and the denominator is the total of the two. So 4900 oblique 50,000. And for specificity, this is the numerator and this is the denominator, which is actually the sum of the two. So 94050 upon 95000 is the, this ratio is the specificity, and 4900 upon 5000 is the sensitivity. So let us go with this formula here. So this is the numerator for sensitivity, this is the numerator for specificity, this is the denominator for sensitivity, and this is the denominator for specificity. So this is how you should go, and you will get your values like 98% sensitivity and 99% specificity. So this is just a repeat of whatever we have discussed previously. So I think based on this you can easily calculate the answer and that will help you. Then next question, which one of the following is defined as an average number of children a woman would have if she were to pass through her reproductive years bearing the children's at the same rates as the women now in each group. Now here there are few definitions which you should know, and these are very confusing, but yes, very important from exam point of view. So one thing is average number of children, right? So this is very important here, average number of children in the reproductive years and bearing children at the same rates. So these are the 3 points which are included in the question. Average number of children throughout the reproductive age period, bearing children at the same rates as the women of each age group. Now the options are age specific fertility rate, general fertility rate, net reproductive rate and total fertility rate. So we will take these definitions. Yes, out of all the easiest one is net reproduction rate. Now here let us take this one only, net reproductive rate. Now in net reproductive rate, the important clue is mortality factor, right? So in net reproductive rate, important component is mortality factor. So here the definition goes like this: average number of daughters a woman would bear who survived to the reproductive age. So considering the mortality. So the moment you have any mention of mortality within the definition, you can go to net reproduction rate, right? So here it's about daughters of female child considering the mortality, that net reproductive rate. Now total fertility rate. So again we can write here total fertility rate. Now here the description is average number of children a woman would have if she passes through the reproductive age, that is 15 to 49 years, and experiencing the current age specific fertility rates, right? So this is what is given in the question, that all children in the reproductive period and considering the age specific fertility rates. So that was, which is something given here. So average number of children throughout the reproductive age group bearing children at the same fertility rate. So this is the total fertility rate, which is the answer here. Here we don't consider any mortality. So again, important thing, no mortality in consideration, and age specific fertility rate is considered here. So age specific fertility rate remains constant here. So this is constant. Then the third one is GFR, that is general fertility rate. So let us take this general fertility rate, and here the number of live births per 1000 women of reproductive age group in a given year. So again this is number of live births, that's very important, per 1000 women of reproductive age group. So here the important clue is live births. So that's journal. And age specific fertility rate, that is number of births to a woman in a specific age group per 1000 women in that age group. So this is again related to the specific age group of the females. So that doesn't make much of a difference, but the important ones are general fertility rate, net reproduction rate, and total fertility rate, which are very frequently asked. So net is the easiest to remember because here mortality is counted. In journal you can take the number of live births, and in total you can take the consideration of age specific fertility rates, right? So please remember this. H Singh, bache, your question is like not related to this topic. Okay, so this is how you should remember. So at least remember these three: general fertility rate, net reproductive rate, and total fertility rate. These are the ones which are very frequently asked, and please don't do any sort of error in this question. The next question: which of the following are beneficiaries of services provided under the ICDS, Integrated Child Development Scheme? So here we have to mark like which are the beneficiaries of this scheme. Now here this scheme is applicable to pregnant women, right? So because they need supplementary nutrition, health checkups and counseling. So pregnant women. After that, children less than 6 years of age are the primary beneficiaries. They need supplementary nutrition, immunization, preschool education. And then adolescent girls, they are covered under one scheme, that is scheme for adolescent girls, which is linked to ICDS. Right? So pregnant women, children less than 6 years of age, and adolescent girls. So these are the beneficiaries here. So adolescent girls, pregnant women, child less than 6 years of age. So this comes out to be the answer here. There is no mention of adolescent boys as the beneficiaries of ICDS. So adolescent girl, children less than 6 years of age, and pregnant women. So please remember for ICDS, because this is also one very favorite topic for exam setters. The next question: the cost of implementation of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Now these kind of questions are very common. Which program is funded by which agency, state government or central government or some other organization? So for Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Now here this is a centrally sponsored health insurance scheme, and this is aimed at providing financial protection to the poor and vulnerable families, and this is shared by both the center and the state government, right? So both the central and the state government are going to support this yojana, where the usual is 60-40, means 60% in by state central and 40% by state in most of the states, but in northeastern and Himachal Pradesh or Uttarakhand hilly areas it is 90:10. It means 90 by the center and 10% by the state. And for union territories without any legislature, it is 100% central funding. So you should know this funding pattern, and private institutions are not responsible for funding. They may participate as empaneled hospitals but do not bear the cost. So on a gross note, this Pradhan Mantri Jan Arogya Yojana, it is funded both by center and state. In majority of the state it is 60-40, but in northeastern or hilly areas like Himachal or Uttarakhand it is 90-10, but for union territories it is 100% central funding. The next question again from Entomology. A water body was inspected to look for the presence of mosquito eggs. It was observed that there are boat-shaped eggs laid singly and not in clusters. The eggs also has lateral floats. Now, which of the following diseases is most likely to be spread by the mosquito whose eggs were found? So, we have to identify which mosquito eggs are these, and then we have to correlate the diseases which are spread by that mosquito. So, firstly, let us write the features of the egg given here. They are boat shaped, clear, laid singly, it means not in clusters, and they have lateral float. So, these are the features of the eggs which are laid by the mosquito. So, boat shaped, laid singly, lateral floats, and these are classical for Anopheles mosquito. Right? So, boat shaped, singly, lateral float, these are classical for Anopheles mosquito. And what are the diseases which are caused by Anopheles? I think everyone can answer, this is malaria. So, the Anopheles, the eggs are boat shaped, lateral floats, single, the condition is malaria. For other mosquitoes like Aedes, right? So, for Aedes it is single without any float, but more importantly it is cigar shaped, and Aedes causes dengue, chikungunya. Culex, the eggs are in rafts and that can lead to Japanese encephalitis. So, for the time being, remember boat shaped, singly laid eggs in having lateral floats, think of Anopheles which can cause malaria. Okay? So, that is very important. So, next question. Now, again it is a definition based question because definitions are very frequently asked in PSM, and I am requesting again and again, please don't do any sort of error in these kind of questions because these are scoring questions, and PSM overall is very scoring. Easily you can score 70 to 80% provided you are perfect with the concepts. Now, which one of the following best defined as the interval between the receipt of infection and the maximal infectivity? So, let us write here receipt of infection to maximal infectivity. It means the patient had the infection and now he is having maximum infectivity. Now, what is this period known as? This is the classical definition of generation time. So, this is the classical definition of generation time. Now, there is one more similar sounding term, like from the receipt of infection till the first manifestation or appearance of symptoms, we can write appearance of symptoms. Now, this is known as the incubation period. So, see a very faint discrimination between the two definitions. So, if you are not perfect with the definitions, you are bound to commit mistakes. So, please don't do that. The moment you have the word maximal infectivity, the answer has to be generation time, and if it is about the appearance of symptoms, the answer has to be incubation period. Okay, that's very important. And then third is latent period, where there is beginning of infectiousness. So, if I write the third term like this, beginning of infectiousness, then you will call it latent period, right. So, see initial word is same, but the ending word is different, and therefore the entire meaning changes, right. So, please be perfect with generation time, incubation period or latent period. And then from the first case, obviously there will be many more cases, and that interval is known as the serial interval. So, serial interval from the primary case to the secondary case, and obviously this is equal to the incubation period. So, that is serial interval. So, primary is the one which is getting the disease initially. So, firstly involved, that is primary case. Now, this primary case will spread the disease to others, and then others will be known as secondary case, right. So, this is secondary case, primary case definition, and this duration is again equal to incubation period. So, primary case is the one which is firstly involved, and now in this there is one more definition, index case. So, again this is some similar sounding term, index case, because we discussed primary case or secondary case, but here is it index. Index means which comes first in the knowledge of investigation. Clear? So, the case which firstly comes in the knowledge of investigators, that will be known as the index case, right. So, see, there are so many definitions which you have to be very good with, otherwise you are bound to do mistakes, which is not acceptable at all. The next question, consider the following: intravenous tubes, catheters, gloves, blood bags. Now, which of the above mentioned biomedical waste will be segregated in the red bag as per the Biomedical Waste Rule Management 2016? IV tubes, gloves, catheters and blood bags. What is to be discarded in red bag? Now, red bag is meant for discarding contaminated recyclable plastic waste. Contaminated recyclable plastic waste. Now, what does it include? Intravenous tubes, it includes catheter, it includes gloves, it includes urine bags, it includes syringes but without needles, and IV sets. So, grossly this is all plastic components. So, IV tubes, catheter, gloves, urine bags, plastic syringes without needles, because needle will go into the semi transparent puncture proof container. Okay. So, the sharp will go here, and IV sets. So, these are disinfected and then they can be recycled. So, plastic waste on an average you can think of red bag. Now, blood bags are not disposed in red because they are having blood. So, they should go into yellow bag. Human anatomical waste or soiled waste with human secretions or blood. So, here this is what we have discussed before. So, blood bag should go into yellow and not in red. For red, it is all plastic recyclable material. The next question, in a town, a study was carried out to determine the role of cigarette smoking in the causation of the lung cancer. Now, it was found that a total of 7,000 people in the town were smokers. Out of them, 70 developed lung cancer. Right? In the same town, 3,000 people were non-smokers. Of them, 3 developed lung cancer. Now, what is the attributable risk ratio. Now here you have to take two words, exposed and non-exposed. Exposed means exposed to the risk factor. And in this question, what is the risk factor? The risk factor is smoking. Clear? The risk factor is smoking. So, how many are smokers? 7,000. How many are non-smokers? 3,000. So, exposed means the ones which are smoking, 7,000. Non-exposed means non-smoking. And then out of this, how many are developing the disease? Here it is 70. So, 70 out of smokers and 3 out of non-smokers. So, these are the ones which are developing the disease, that is the lung cancer. Okay. So, exposed having disease, non-exposed having disease. Now, we want to calculate attributable risk first. And what is the attributable risk? It is actually the difference, right. So, this is actually the difference. So, we have to subtract two values. Now, what are those two values? It is the incidence among exposed to the incidence among non-exposed. Now, incidence means new cases. So, new cases among exposed will be 70 upon 7,000. Similarly, new cases in non-exposed will be 3 upon 3,000, right. So, we have to write the number of cases as numerator in both the columns, and exposed, this will come to be denominator, non-exposed will come to be denominator here. So, this will give you incidence in exposed and this is the incidence in non-exposed. Non-exposed means non-smoker. So, this is how we will get the two. So, now we will calculate the incidence. So, in smokers or exposed, this is the number of new cases out of all those who are smoking, this is 1%, and then among non-exposed means number of new cases amongst all those who were not exposed to smoking, means they were non-smokers, and this is 0.1%. So, we will take the difference, that is attributable risk, and so 1 minus 0.1 is 0.9%, and when we have to take the attributable risk percent, then we will simply take the denominator as incidence among exposed. So, this will be something like this, attributable risk into 100 upon incidence among exposed. So, we will get the answer, that is attributable risk percent, right. So, this is how you need to solve this question. So, again this is based on the formula. If you know the formula of attributable risk and if you know the definition of attributable risk, then only you can solve such a easy question. So, you should know the formula first, then it becomes very easy to score in such questions. Then the last question for today's session, a town in the hills had mid-year population of between 2,50,000, and then during the same year the death registry recorded 1,500 deaths, and it is because of which disease? Tuberculosis. Now, what is the specific death rate for tuberculosis? Now, the term is specific death rate, and when we use the word specific, means we are specifically asking about some condition, and this is the TB here. So, specific death rate. Now, what we have been given here? We have given the mid-year population, that is 2,50,000, and we have been given the death rate, that death numbers the number of deaths, which is 1500. So what we need to do? We have to simply take this as the numerator. So this will come out to be the numerator, and this is the denominator. So death due to specific cause as the numerator and mid-year population as the denominator into 1000. So you will get this value here. So 1500 are the diseases due to tuberculosis, 2,50,000 is the mid-year population, and the answer comes out to be 6. So this is the specific death rate for a particular disease. So here you can write, like if I write the formula, specific death rate. So number of deaths due to a particular disease, and the denominator is mid-year population. Clear? So this is specific death rate. Now there is one more term, case fatality rate, right? So case fatality rate. Now what is this? Now here again you have to take the numerator same, so number of deaths due to that particular disease, but the denominator will change. So in such case the denominator is number of total cases of that disease, right? So number of total cases of that disease. So this is the case fatality rate. So see, the two conditions, the two terms are different. The specific death rate, the denominator is mid-year population, and in case fatality rate the denominator is total number of cases, not the mid-year population, right? So in PSM definitely there is lot of scope for scoring, and I will request again and again, please revise the concepts properly, revise the formulas, the way of calculating some important parameters, and I am very sure you will score good in PSM. So this is the end of this session. I am very sure you must have enjoyed the session. Thanks for joining. Very shortly I will come up with another subject. Till then, keep on studying. God bless.